This is a case of a 71-year-old gentleman who initially presented with some urinary obstructive symptoms and was found to have a PSA of 10.2 in a nodular prostate on exam. He underwent transrectal ultrasound and biopsy and was found to have multiple cores of Gleason 9 cancer and elected for a prostatectomy, which confirmed these findings along with stage 3 disease and extracapsular involvement. After surgery and recovery of his symptoms, he was treated with adjuvant hormonal therapy with leuprolide and with IMRT radiation therapy 7800 Senegray. Unfortunately, his PSA natered but continued to rise on his hormonal therapy until 2016 in April when his PSA reached up to 47. At this point in time, his scans were still negative for disease, but he was clearly castration resistant and was started on enzalutamide therapy. He tolerated this well initially and had a nice decline in PSA down to 12. However, after that nadir, his PSA began to rise rapidly, and within 6 months, now by October 2016, his PSA was back up to 76. He also had an elevated alkaline phosphatase, now up to 268, and symptoms with increasing fatigue and some back pain. Not surprisingly, then, on scans, he was also noted to have multiple new osseous metastatic disease in his spine and pelvis. The patient was started on radium-223. His enzalutamide was continued, and he was treated with 3 cycles of therapy, after which time his PSA had declined down to 31, his alk-phos all the way back into the normal range at 80. His symptoms had improved with some improvement in his fatigue and stabilization there, and actually increase in his physical activity. And on scans, we saw stabilization of his metastatic burden. This case really illustrates to me one of the spectrum of cases that we see in prostate cancer, and that's of accelerated disease. This is a patient that presented with some urinary symptoms, with some palpable disease and high volume disease. You know, that's only about 15% of prostate cancer patients that are diagnosed each year present with this kind of Gleason 8 to 10 cancer. And not surprisingly, it's usually associated with an elevated PSA, with symptoms, or with, multiple cores positive. And these are the patients at surgery or radiation therapy, we treat them for stage 3 disease because commonly that's what they have. And it's not surprising. Many of these patients who do undergo surgery end up needing radiation afterwards. What's a little bit unusual in this case is how quickly this patient progressed both through primary hormonal therapy as well as secondary hormonal therapy. Not all Gleason 9 cancers will do that, but some do. And it suggests that up front, this is a disease biology that's not completely dependent on the androgen axis. When I see that kind of a case, somebody within a couple of years of diagnosing, presenting from localized disease to now castration-resistant metastatic disease with really short intervals of response to primary hormonal therapy, I'm already thinking, even though I'm going to use my secondary novel hormonal agents, this is a patient that's going to need a broader array of treatment strategies. These are the patients we also like to do genomic profiling on to look at, are there other alterations and mutations? Could there be DNA damage repair pathways or others that we'd want to target? But I'm thinking about my cytotoxic therapies, chemotherapy, my radiopharmaceutical radium. These are the kinds of therapies that these patients are going to need that can treat tumor more indiscriminately than a single pathway.